get a good nurse and they're easy to teach, they're teachable. It's just as easy to teach them from the beginning how to be an emergency nurse than it is to get someone with a couple of years of med-surg experience, which isn't applicable really to the emergency department. I've always thought that new grads in the ER was a good thing to do. I mean, an ER residency, that's awesome.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing. And if you are listening to this podcast in real time, happy Emergency Nurses Week to you. Thanks for listening to the podcast. I really appreciate it. Be sure to share the podcast with people you like, people you don't like. Share it with all the emergency room nurses you can think of. Now, I am telling you, I just got back from AOEN 22 in Denver, and I had a great time. I got a chance to meet a few people that I have interviewed on the podcast but had not yet met in person. That was super cool. I got to meet a bunch of people who listen to the podcast. That was super cool. And I got a chance to see old friends and people I see like maybe once or twice a year. So that was amazing. Another super cool thing that happened in Denver for AOEN 22 is I got inducted as a fellow into the Academy of Emergency Nursing. And I just want to mention that on here because I have you guys to thank for it. A big part of my acceptance into the Academy was based on the podcast and the fact that as many of you listen to this podcast, and maybe we are making some kind of small difference in the specialty of emergency nursing. So for that, I thank you. Thanks for helping me make a difference, and thanks for listening to the podcast. And I just can't thank you enough for that. Now, let's talk about our episode this week. Our episode this week is with one of my favorite nurses in Texas. This nurse is somebody that I got to know when she was on the board, the ENA board. She came down to New Mexico, and I got a chance to meet her there. And then when I moved to Texas, she was one of the first people I got to see and greeted me at my very first Texas ENA meeting. That woman is the one, the only, the amazing Sally Snow. And you are going to hear a little bit of her story here about how she has dedicated her career to serving emergency nurses just like you. You are really going to enjoy this episode with my friend, Sally. So you became a nurse in, you said 1974?
Correct.
How much did you make? How much did you start off making as a nurse?
$750 a month.
Holy cow. $750
You know,
a month.
I remember thinking if I could just make $1,000 a month, I would be rich.
Right? What does that come out to hourly? That's not much. I don't remember. I would have to do
I don't
the math,
either. I worked 3 to 11, and I know there must have been a differential, but I don't remember what it was. If there was one, it was, $1 an hour or something like that.
Yeah, it certainly wasn't much, right?
And the best part of that, the very best part of all of that is I worked at a county hospital where there was one attending staff physician, and he was the medical director. And he came in sometimes about 9 o'clock in the morning, and by 3:30 he was out of there. And that was Monday through Friday. And the rest of the time, the nurses taught the brand new physicians, interns, and residents how to keep people alive.
No kidding.
There was no attending staff physician for several years, except from 9 a.m. to 3:30 p.m. And I think we probably had a 4th-year orthopedic surgery resident in the house. We had a 4th-year OB-GYN resident. We had probably a 3rd-year family practice resident. But between about 2 in the morning and 7 in the morning, there was an intern. And on July 1st, that guy had been a doctor for a day. Yeah.
You're like going, yeah, you are the least experienced person here. So just listen.
Yeah, and if they didn't listen, there were several nurses, some of which were LVNs who worked in the emergency department, who told them, look, you'll listen to me today or you'll listen to me tomorrow, but you will listen to me. And together we can keep people alive. And that was literally the truth.
How funny is that? Holy cow.
And there was no doctor in any ER in town after 6 p.m. at all. So every ambulance after 6 p.m. came to the county hospital.
Wow. I remember
it was fun.
I remember, well, even when I first started, and I started working in the ER in 98. So, quite a few years later, but still we were at the point then in the emergency department where at night the doc would go and sleep. And if there was a patient, you go knock on the door and wake them up. And most of the time by about midnight, they were ready to go wind down. And, sometimes they'd go back there and sleep, and sometimes they'd just go back there and just read or do whatever they were doing. But there wasn't much going on from about midnight till about 5. About 5, it would start picking up. So
that's the way it was at the children's hospital. They'd go to bed, and you knew which patient that you could wake them up for and which patient you couldn't wake them up for.
Yeah, you're like,
that still is going on in the rural town I live in right now. I mean, the ER doc is in bed at night because they work 24-hour shifts.
Yeah. A smaller ER that I worked for a little while, or worked for the hospital, and in the ER particularly, it wasn't uncommon for docs to take a little nap at night if things were okay. If they were busy, they wouldn't. But if they had the opportunity, they'd be like, "I'll be napping in the sleep room, so just call me if you need me." And the only
making a lot of money.
and the only other doctor in the hospital, the only other doctor in the whole hospital, was an anesthesiologist who was likely upstairs in a sleep room. And if they weren't upstairs in a sleep room, they were like 10 minutes away at home. They were
or tied up in labor and delivery.
Yeah. And that's what they were on call for, is labor and delivery. We had a labor and delivery there, and they mostly were busy there, like if needed. So a lot of them would sleep there at the hospital. And half the time we'd never call them, but I'll never forget one day I called one of the docs and I was like, "Hey, are you in the building?" And he goes, "Oh man," he goes, I'm not on call in that hospital. I'm on call at this other hospital." And I was like, "Oh shit, you are?" I go, I got that you're on call here. And he goes,
"I got your name on my call list."
He goes, no, I'm at the other hospital. And I was like, "Well, shit. Okay." He goes, "Well, let me get you the phone numbers to who's likely there." And I was like, "Okay, that's great." And I'm sitting there going, as all this was going on, we had a patient who was very difficult to intubate in the ICU that the ER doc was trying to intubate and having difficulty. So I look at the ER doc, I'm like, still working on that anesthesiology thing. And then like a minute later, the doctor calls back and goes, I'm sorry, I'm in the hospital. I didn't know where I was. I'm here. Where do you need me? I go, come on down. Come on down to the ICU. And he comes down to the ICU and he's rubbing sleep out of his eye. And I'm like, he's like, "What's going on?" I go, "We have this patient here who's really hard to intubate that our doc is trying, and he needs help." And he's like, "On it," and just jumped in, did a fabulous job. And, he was so apologetic. He's like, "I'm so sorry." And it's like, "It's okay. Like, I get it, man. I would be the same way if you woke me up in the middle of the night. I don't know where the hell I'm at."
Kevin, in 1974, there were no paramedics in the city of Fort Worth.
No kidding.
None. We trained the first class of paramedics, and I think there were 12, maybe 15 in the class, and they graduated in 1975. Wow. So it took a long time for the physicians to accept that the paramedics could do something in the field. I mean, they were very resistant. They would say, "No, just load them and bring them on in."
Yeah.
And they finally got to where they would, give them orders to do an IV or give a medication or whatever. But yeah, we trained the first class in Fort Worth in 1975.
No kidding. Holy cow. Wow, you've done some stuff. That's cool.
There was no such thing as an ER doc.
No,
our
docs,
physicians, right? Yeah, we had a family practice residency, one of the better ones in the country. And all of our ER docs were, 3-year trained family practice docs that wanted to stay on and do ER.
Yep. Wanted to moonlight, get a little extra time, right? Yeah.
And by that time, some of them, or a few years into it, some of them were working at some other hospitals were using our residents to staff their ERs after 6 o'clock at night. So overnight, they had a JPS resident.
Yeah. Holy cow. Think of the changes you've seen in your career. That's super cool. That's super cool. What do you think has been the biggest change in your career since when you started as a nurse to when you, so when did you retire?
2017, January of 2017.
Holy cow. And what do you think was the biggest change in that time, from the time you were working full time to the time you stopped?
Probably certification for nurses was the most important thing that happened, because it really set aside those nurses that were certified that demonstrated that level of competency. And truthfully, it was the same way for physicians, because again, there were no emergency medicine residencies at all. So they got no formal training to take care of emergency patients until quite a few years in. There was no such thing as a designated trauma center. And early in my career, I mean, Parkland was the first designated trauma center that I know of in the state of Texas. Before there was a trauma system in Texas, they were ACS certified, but that was one of the few.
Yeah.
There were certainly no trauma trained surgeons. They were just general surgeons.
General surgeons just did what they had to do.
Mm-hmm.
Yep, absolutely. So.
Yeah, and when I went to the Children's Hospital, I looked back on some of the patients that we took care of at the county hospital that were children, especially babies, that were so badly mismanaged that because we didn't know what we didn't know. I mean, we might have a pediatrician attending that just happened to be in the hospital if we needed somebody, but for the most part, we didn't know what we didn't know. I mean, we didn't know about fluids and how differently you resuscitated a kid than an adult. It was just very, very wing it.
Yeah, wing it and figure it out. So why did you become a nurse? Why nursing?
That I was thinking about that because you had told me that you might ask me that. The very first thing I ever really wanted to be in my life, I think when I was maybe 8 or 9 years old, was a Navy nurse, because my dad was in the Naval Reserve and he would go on cruises, for 2 weeks every summer. And he would tell me, that the Navy nurses were really special. And I just, as a child, wanted to be a Navy nurse. But in high school and the first couple of years of college, I had no interest necessarily in being a nurse. I was a science major. I loved science. I loved, anything biology, zoology. I wasn't a big chemistry or physics person. But I got an associate degree in science at the junior college in the town where I lived. And then when it came time to go to Texas Tech in Lubbock, they wanted to know what I wanted to be when I grew up. And I was like, I don't really know. What can I do with this science degree? And they said, well, you can either do research or you can teach. And I was like, no and no. I'm not real interested in that. And they said, well, what about a healthcare profession? So I said, okay, what do you got? And they said, well, how about a physical therapist? And I said, okay, well, that sounds like fun. And then they put me in a couple of classes that quickly changed my mind about that. The first one was physics. And the first time the professor put a delta on the board and said, delta this, delta that, I was like, that's a fraternity. I'm out. And then my philosophy class, when the professor said, 150 times in 1 hour, and I made hashtags every time he did it, I was like,
gosh.
I
Isn't
can't do
that
this.
the worst?
Yeah.
That's always
it still
the worst.
Makes me crazy. That, and like make me crazy.
I'm with you. I know what you mean.
I had to get out of that philosophy class, and certainly physics wasn't in my future. And so I went back to the junior college where I'd graduated the year before, and there was a new campus of the University of Texas System School of Nursing opening in Fort Worth the following fall. So I took sociology, statistics, and child growth and development. It was the only 3 classes that I needed prerequisite-wise to go to nursing school. And so I applied and got into the new campus in Fort Worth and left Levelland, Texas, where I grew up in the Panhandle, and went to Fort Worth and got a nursing degree. It was the first baccalaureate class of the University of Texas System School at Fort Worth because there was a diploma program at John Petersmith, which was the county hospital, and that's where the campus was for the nursing school. And so they phased out the diploma program and phased in the baccalaureate program, and I was in the first class of the baccalaureate program.
How cool is that?
Now it's UTA School of Nursing, but at that time, the System School of Nursing had 5 campuses, and it was a pretty powerful school. So powerful that the University of Texas medical schools decided that needed to be broken up. So they broke up that system school, and put those campuses under their universities in different towns where they were located. There was a new one in El Paso, one in San Antonio, one in Houston, one in Fort Worth.
So that's why it's UT Arlington, UT Houston, UT. Because I had no idea, because I work for UT as casual faculty in the nursing program, and it's always UT Houston, and I was like, UT Houston. What difference does it make? Like, it's UT Houston.
My diploma says University of Texas System School of Nursing.
That's cool.
So
that's really cool.
I thought so.
At what point?
I used to say all the time, I didn't go to UTA.
You're like, no, I went to a different school. Same place, different school.
I went to D school.
One of the things that the University of New Mexico is kind of like the University of Texas. They're the major state-funded university. And they always say, we are the University of New Mexico.
Right. Like the Ohio State University.
Yeah.
And the University of Oklahoma.
That's right. They're like, we are the university. Because there's a couple in New Mexico, but they're like, we are the one.
Right.
So now there's so many darn nursing schools in Texas, you don't know what to do. Can't swing a cat without hitting a nursing school. So
I know.
So at what point were you sure you made the right decision?
Real early on. I mean, in nursing school, like I said, our campus was in the family health clinic on the campus of the John Petersmith Hospital, and the overhead paging system came through our nursing school class because it was in the family health center, so the docs had to hear the paging system. And I loved it when they would page someone's stat to the ER. I was like, oh my God, let me go. I want to go. And I was kind of a natural. I don't know why I didn't think of doing that to begin with. It was definitely what I was meant to be.
Yeah. And was it always ER nursing?
Mm-hmm. Absolutely. I never considered working anyplace else. And when I transitioned to the trauma program, it wasn't that big of a leap. In fact, most trauma coordinators or trauma program managers are ER nurses. Absolutely. Because that's where the majority of the fun care takes place in a trauma is in the ED. So it was a natural transition for me.
Yeah, very cool. That's awesome. I love hearing that when people find their thing. So
yeah. You know, I've always said that nursing is such a wonderful job for anyone, but especially for a woman, because you can work anywhere. There's always going to be a nursing job wherever you live. If if your husband gets a promotion and you want to move to New York City, all you have to do is go apply for a job. I mean, it's a wonderful profession for anyone. And, there's also male nurses who move to take a position because their wives got a big promotion. So it's just something you can do anywhere. There's never going to be no need for a nurse.
Absolutely. I tell the new nurse residents, because we have a nurse residency program, and I tell them all the time, I said, you have the golden ticket. You have the golden ticket. Right. You will always have a job. You'll always make good money, and you'll always have work. You're never going to not be without work. And I mean that when I say that, because truly, I quit I left New Mexico and came to Houston, and man, I had a couple of job offers before you knew it. As soon as I started applying, things were just lining up. And even when I got fired from a position, a nursing position, which yes, I got fired. I had a position the next day. It was like, it's fine. Yeah, it's fine. So it's always been one of those where it's quick to just jump right into something else. So For sure.
And see, that's something I never did. I had 2 nursing jobs, worked for 2 employers as a nurse in the whole 40 years I worked as a nurse.
You don't see that very much anymore.
Yeah, I'm not a big fan of change, I guess. So I had several different jobs at Cook. Well, I had 2 jobs at Cook. I was the director of the ER and I was the trauma program director. But I found what I wanted to do and stayed with it.
That's awesome. That's really awesome. What in your years, so you started as a new grad nurse, what do you think of new grad nurses starting in the ER now?
I absolutely think it's the right thing to do. I think if you get a good nurse and they're easy to teach, they're teachable, it's just as easy to teach them from the beginning how to be an emergency nurse than it is to get someone with a couple of years of med-surg experience, which isn't applicable really to the emergency department.
Sure.
I've always thought that new grads in the ER was a good thing to do. I mean, an ER residency, that's awesome. Yep. If you could take those GNs that I'm talking about that were trained on the job and put them in a didactic learning situation for a day or 2 a week for a few weeks or months, good grief, that's awesome. That is the perfect situation.
Absolutely. Absolutely. I totally agree with you 100%. So, for sure. So, what do you think is the key to success as a new grad nurse?
Listening. If you don't listen to the person that's trying to help you learn what you're doing, because let's face it, you and I both know that you don't learn to be a nurse in nursing school. You learn to be a nurse on the job. I was trained by a couple of LVNs that taught me everything I know about the clinical skills of emergency nursing. I mean, they made sure I knew what I was seeing when I was seeing it and what it meant, what I needed to do about it, what was important, what wasn't important, what we needed to tell the doctor, what we didn't need to tell the doctor.
Yeah.
And they taught me how to be an emergency nurse. Yeah. And I think that a lot of people would say that about their mentors as a new nurse.
I 100% agree. Like, I had great mentors, great people who raised me and taught me how to be a nurse. So, yeah, absolutely.
You sure don't learn it in nursing school.
No, you learn a lot of stuff in nursing school, but you don't learn that.
Right. You learn a lot of the why you do things, but not a lot of the how.
Yeah.
You learn the how on the job.
And I think the how is getting better. I think they tried to do a pretty good job of trying to communicate it, but there's nothing like being there in the real time with the patient. Like, it's just
right. And I think that probably the how is where the residencies and the internships really shine, because that gives you an on-the-job training opportunity. And then, the next day, if you could go into class and say, now, why did we do that? Or what's the indication for that medication? What's the contraindication for it? There's a lot to be said for that opportunity.
Agreed. I agree 100%. So tell me about your transition from bedside to leadership. How'd that go? Sounds like you're in the same organization. That's sometimes awkward.
It was. And I'm glad you said that, because, I'll never forget what it was like when I realized that I had gone from one of the nurses, to the enemy. And I was so hurt by that. I'm a real sensitive person, and what people think about me is very important to me. So the first time I got blamed for something that was a management decision, I was devastated. I was like, oh my God, how can you turn on me? I was your baby a week ago, and now I'm the enemy. How can that be? Yeah. But it's true. I mean, a lot of people don't get it, and it's very hurtful when you finally do get it. So, there's the line that you cross when you become the manager, and you have to deliver the message of the management team and the administrative team, even though you may not like it. It's difficult. It's hard to get there, but I always loved that. I mean, truthfully, I was a bedside nurse for 1 year before, truly a staff nurse, before I transitioned to the assistant head nurse job. And so I was a bedside nurse 2 out of the 5 days I worked because I was in charge while the head nurse was off. And then when we went 12-hour shifts, I was in charge every time I worked. So it was fun. I loved being in charge in the ER. I loved being in on the scoop. I loved being able to go with the cops when they came in to work a crime scene. The crime scene detectives in Fort Worth taught me how to fingerprint almost immediately. Awesome. And they would come in to do their little investigation. If there was a homicide, they'd come in, hand me the fingerprint cards, and they'd do other things. So it was, I loved being in the know about what was going on.
That's kind of cool.
About everything.
That's kind of cool.
I'm kind of nosy like that.
A little bit of a busybody. If you figure out what people are doing. Like maybe, not going to commit, but maybe.
Maybe so.
How cool.
The people who know me will know the answer to that.
People who know will be like, oh yeah, I know the answer to that.
I know her.
Oh. What do you think right now should have leaders' attention?
PTSD and burnout. Yeah. I think we won't know the extent that this COVID-19 pandemic has taken on emergency nurses or nurses, period, and physicians.
Yeah.
Until the crisis is over and they've had a chance to wake up, because I think they've been operating on instinct and in a fog for quite a few months now.
True.
And when it's over, they're going to realize that the trauma has been far greater than they realize.
Absolutely.
And I think we have to do, as an organization, I know the ENA Foundation last year quickly shifted our normal campaign for raising money and funded those COVID relief grants because we saw our peers struggling, some that were furloughed because they, were working in hospitals that weren't seeing a lot of patients other than COVID. And people that weren't able to, their spouses had been laid off. They weren't able to pay their rent and buy groceries. Yeah. And we stepped up really quickly to initiate those COVID relief grants to help people get by.
Yeah.
And I really think that the degree of trauma that they've been subjected to is going to come back and haunt them real soon. And we need mechanisms to be there for them. We need, employee assistance programs and counseling and trauma-informed care so they can.
So much they need.
Yeah, we can be there for them.
Yeah, for sure. For sure. What advice would you give to a new nurse getting ready to start in the ER?
Just take it in. I mean, if you're an ER nurse, you're going to know it real soon. And if you're not, you're going to know it real soon. I used to say when I took over the pediatric emergency department, I could take an emergency nurse and make them a pediatric nurse. I couldn't necessarily take a pediatric nurse and make them an emergency nurse. No. So consequently, when I left JPS and came over to the Children's Hospital, several of the nurses that I worked with at JPS came with me. And it was an easy decision to hire them because I knew what kind of emergency nurse they were. I knew they could learn pediatrics.
Absolutely.
For sure.
Absolutely. Absolutely. One of the things I find is that a lot of nurses are uncomfortable with pediatrics, but there's a lot that, have done it enough that they're like, we got this. It's okay. So.
Well, and that's the beauty of ENPC. ENPC takes the mystery out of it, takes the surprise out of it in a lot of cases. And I used to ask my ENPC students every time we'd have a class, are you leaving here feeling better about taking care of kids than you did when you got here? And every one of them said, absolutely.
I would
tell people who fail the test. Yeah. No, I really didn't. I mean, it was so obvious that the things they were learning about how to recognize when a kid's sick and take some steps to keep them from getting critically sick or injured was worth everything.
Yeah.
It was the key to it.
Tell me about a patient you'll never forget.
Okay. I've seen a lot of tragedy working in the county hospital in the emergency department. And I remember a young girl, probably 22 or 3 years old, if that old. She was at home with her 5-year-old, and a strange guy came to the door and told her that he was there from the electric company and needed to come in and check something. And she let him in. And he locked her 5-year-old in the bathroom, chased her out in the backyard, and a neighbor kid who was home from school saw it, called the police. He got her back in the house, stabbed her to death, and she came in just with multiple stab wounds. And I had to stand in the room when her husband came in to identify her. And I'll never forget him saying to me, "No one ever hurt her." And she was just gone. And he was at work. And he was called to the ER to identify her, and that was the last time he ever saw her. And there's so many of those situations that take such a toll on emergency nurses that they don't think about. I mean, I know for a fact that I suffered from PTSD from things like that for 14 years in the ER, but I never knew that. Yeah. There was no, post-traumatic stress debriefings. There were no, it was just suck it up and get back to work. And I mean, it got to where every person that came in that was raped was me. Every grandfather that came in dead was my grandfather. Every child that came in dead was my child. And I finally realized I had to get away from that kind of tragedy. So there's a lot of patients like that little girl, but I'll never forget what her husband said to me.
Yeah. Oh, what a tragedy.
It was.
What a tragedy.
Still is. I could cry really hard right now.
No crying in podcasting.
Isn't it weird how you keep things like that in until somebody asks you about it and you haven't thought about it in 40 years, and all of a sudden it's just as painful as it was that day?
Hurts just as much as it did that day. Hurts just as much. Absolutely. And then it always triggers me to think about the many peds that I've seen that have died in various ways that.
Oh yeah.
Oh man, too many.
I had a 6-week-old one time stabbed by her mother, who was a military wife, and suffering from postpartum psychosis. Yeah. She stabbed this infant in the chest with a pair of scissors. Oh. And she was just completely oblivious to what she had done.
Holy cow.
Yeah.
Oh.
Yeah.
It's a wonder we can even get out of bed in the mornings.
It is.
How do we?
And people that don't do this job don't get it.
I have no idea.
They have no idea.
How do you deal with that? How do you process that? How do we get the next generation of nurses ready to deal with that? And how do we teach them to process so that they don't end up in a puddle?
I think there's a lot of value to things like, critical incident stress debriefing, where if you could talk through it not long after it happened and articulate what it feels like, you wouldn't internalize it so much and have it, swell for so long. So I think there was a lot of value to the critical incident stress debriefings and things like that took place a while back. I haven't seen one. I haven't been around an ER in a long time, so I don't know if that still happens or not.
Yeah, I think some do and some don't. I think critical incident stress debriefing is some find it very helpful and some don't find it valuable at all.
Right. I think there's a lot of burnout. I know, I read the Facebook groups where emergency nurses make comments, and sometimes I just shake my head and say, it's time for you to go do something else. Yeah. When you can't have empathy for people and compassion for people in situations like you're describing, it's time for you to go do something else. It's not worth it to feel that kind of cynicism and hostility towards somebody who you don't know anything about. You don't know what that person's going through on a daily basis. You don't know what really brought them to the ER.
Yeah, you don't know.
Especially when somebody complains about so many patients coming in with non-emergency situations. I'm like, you know what? If they don't come to the ER, your hospital's not going to need as many ER nurses as they need right now. So be careful what you wish for.
Yeah, we learned that with COVID when they stopped coming in.
Exactly.
Right? And then we were like, wait a minute, where are all the patients? We thought we were supposed to be busy. So,
yeah.
So one of the last questions I'd like to ask for 3 things an emergency nurse should always remember, and 3 things they can just go ahead and forget. Just forget about it.
Well, with my pediatric emergency nurse hat on, I'm going to say that a quiet child is a sick child. They are rarely quiet. If you've got one, you ever had a child, they're rarely quiet when they're uncomfortable and in a position where they're in unfamiliar surroundings. If they're quiet, they're sick. They'll tell you that they're getting sick by breathing faster, their heart rates will go up, their level of consciousness will go down. And if you don't pay attention to that, they're going to go off that cliff, and it's very difficult to get them back when you let them get off the cliff. So
Absolutely.
The key to pediatric emergency nursing is recognizing when they're in trouble.
Absolutely right.
And the other thing I think it's important is to never turn your back on a stranger. We all know that workplace violence is a big problem. And if you aren't aware of your surroundings, if you're not anticipating what might happen next, you can get hurt.
Yep.
And that's something that everybody needs to keep in the back of their mind all the time.
Absolutely right. Absolutely right.
Let's see what they should forget.
Yeah, that's horrible.
I don't know if there's a lot they should forget. You never stop learning.
Absolutely.
You never say, I know everything there is to know about anything, because the minute you do that, you're going to turn around and there's going to be something that you don't know about. And you're going to spend a lot of time doing the wrong thing because you don't listen and learn when you have the opportunity. So
Absolutely.
You never stop learning.
Ain't that the truth? What else can they not forget? Or what else can they go ahead and forget?
I'd rather do things they can't forget, like weighing a pediatric patient in kilograms. Don't ever weigh a pediatric patient in pounds and record it in pounds.
Why?
Because that's where medication errors happen. Medications are prescribed for children by kilogram weight. And if you record pounds and someone writes a medication order based on what they think is kilograms, you're going to 2 times dose that patient. So
Absolutely.
Don't ever weigh a pediatric patient in pounds and record it in pounds.
Sounds like a pretty good thing to forget. Sounds like a pretty good thing to forget.
About weighing them in pounds?
Don't forget. Yeah,
there you go.
Forget weighing them in pounds.
That's correct.
It's all how you spin it. It's all how you spin it.
Lock your scales in kilos. Forget about the doctor that disrespects you.
Okay.
And your coworkers who may try to eat you for lunch, because they'll do that. I've had people tell me, well, why should she get an orientation? I didn't get one. Well, that's exactly why she should get an orientation, because you didn't get one.
Yep.
You kind of got to have a tough skin and let a lot of things roll off your back.
Absolutely right.
As long as you know you're doing the right thing and you verify that you're doing the right thing, keep on doing it.
Yep. Absolutely right. Well, Sally, this has been a lot of fun, and I've kept you way longer than I told you I would. So I appreciate you hanging in there with me.
Okay. My pleasure.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.